Hello, and welcome to the Texas Rex Educational Series. This session is being recorded and will be posted on the texasrex.org webinars page. If you want to review the content or share the information with your friends and colleagues, our speaker today, Dr. David Milasina, will be speaking about Stage 2 changes, overview of Stage 2, core and menu measures, and how clinical quality measures will be handled. All attendees have been muted to block out background noise. If you have questions for our speaker, please post them in the chat block of the GoToWebinar pane. Your question will be read to the presenter at the end of the presentation. If we are unable to answer your question during the allotted time, you will receive an answer via email. First, some information about our speaker. Dr. Milasina is the Chief Medical Officer of the CMS Dallas Regional Office since 1995. He is the regional lead for the agency's value-based purchasing initiatives, including quality reporting and pay-for-performance programs in hospitals, ASCs, and ambulatory care settings. He is also a lead contact for the high-tech EHR incentive programs and is part of the regional team implementing the launch of the health insurance marketplace. Dr. Milasina has previously been the CMS lead for the National Quality Improvement Efforts in AMI, heart failure, and stroke. He is board certified in general preventive medicine, public health, and has a Master's of Science degrees in both public health and medical informatics from the University of Utah. Thank you for joining us, and I will now turn over the webinar to Dr. David Milasina.
Okay, thank you, Veronica. Can you hear me okay?
Yes. Oops. Can you accept I changed the presenter.
Okay, let me do show my screen, I guess.
Yes, right there.
Okay?
Yes.
And I'm assuming that now I'm in control of the slides. Yes, I am. Okay, perfect. All right, well, welcome and Happy New Year, everyone. I'm glad to have the opportunity to present some information about our EHR incentive program and Stage 2 of meaningful use. If you look on the first slide, you may wonder if you're in the right year. That was actually an accident on the slide, but it does give me an opportunity to say that most of the information I will be presenting today is actually not new. It's been around at least since last January, since the high-tech Stage 2 rule was published the previous summer. So it will be review for a lot of you, but since we are in the first year of Stage 2, 2014, it's a good chance to review the information and hopefully answer any questions that you may have during this webinar. All right, so I won't be talking about all of these today, but there's a lot more in the final rule that was published a year and a half ago than Stage 2. There were changes to Stage 1 of meaningful use. Of course, there were all of the details about Stage 2 of meaningful use. There was a lot of information about new clinical quality measures and the way that quality measures will be working for meaningful use in the future. There was important information for Medicare providers related to payment adjustments that are coming next year and the hardship exemptions related to those. And then there was some information related to Medicare Advantage program and to the Medicaid EHR incentive program as well. I'll be talking mostly about the first 5 of these items today. All right, so what does Stage 1 or Stage 2 mean to you? Well, first and importantly, starting this year, there will be new requirements for participating providers who have already met Stage 1 for 2 or 3 years. So they'll have to move up the scale to Stage 2, and so it will be a more challenging implementation of your EHR. It will lead to improved patient care. That's kind of what this program is all about, making use of the technology to improve patient care. And by changing the objectives and sort of escalating the objectives for Stage 2, we're hoping that we can put these tools to better use to improve patient care. And then also saving money, time, and lives. We know that electronic health records have the potential to not only improve clinical care, but also to make care more efficient and to reduce redundancy in the healthcare delivery system. So hopefully we can achieve all these and are moving in that direction. All right, so one question that came up frequently after we published our rule was, so now are there going to be new people who can participate in the program? When we were doing stage 1, there was a lot of interest in the program by people who could not be eligible professionals, and there was a lot of interest in whether they now could join the program. Well, the eligibility for this program is determined by statute under the HITECH legislation, and there have been no changes to that legislation. So the only wiggle room we had with respect to eligibility was a little bit on the Medicaid side in terms of doing some flexibility in terms of volume determination, and then one other thing related to hospital-based physicians that I'll talk about in a moment. But the basic types of providers and types of hospitals that are eligible for the EHR incentive program have not changed. So I mentioned the hospital-based providers, and for those of you who don't remember, for eligible professionals, you cannot earn an incentive in this program if you are considered hospital-based. And the way we define that is if 90% or more of your services are in the inpatient or emergency department setting. Now we heard in the first couple of years of meaningful use that there were some hospital-based providers who felt that that was sort of unfair because while they were working in the hospital, the EHRs that they were using really had nothing to do with the hospital. They were systems they had acquired on their own. They were using them independent of the hospital, and they thought that they should be able to participate in the program. So we listened to those concerns, and we did build in a process for those few eligible professionals where that situation applies, that they can apply for an exception to sort of have the hospital-based designation removed so they could participate. These EPs do need to have funded the acquisition, implementation, and maintenance of the EHR technology, including the hardware and interfaces, and it has to be sort of completely independent and in place of the hospital system. So these will be done on a case-by-case basis, and if you're interested in applying for that, you can contact the EHR Information Center that we'll give you information about at the end of the webinar. All right, so let's jump into stage 2 of meaningful use. That's kind of the main content of the rule that we published. And as most of you know, when we began this program, we realized that not everybody was ready to jump sort of to the full and final implementation and utilization of their EHR system. So we staged it out in gradual implementation of that functionality. In stage 1, our focus was on capturing data in a structured and electronic format and beginning to share that data among providers and between systems, but focusing mostly on the capture of the data. So we have to get something into the system first before we can use it. Now in stage 2, we're going to move along and try to use that information for advanced clinical processes. So try to use the information about the patients that has been stored in the system and make use of that information to improve decision-making about the patient, to improve care coordination for the patient, and other things to benefit patient care. And then eventually in stage 3, we hope to actually achieve some of the improved outcomes, both at the patient level and in terms of financial outcomes related to these systems. For stage 2, right now, we'll focus on the advanced clinical processes. All right, the other big question that came up for stage 2 is, well, when does it start, when does it end, and how soon do I have to get there? Now, originally, when we first started the program, there was sort of a sequence of you do 2 years in stage 1, and then 2 years in stage 2, and 2 years in stage 3. We changed that, and we announced it actually prior to the publication of the rule, and finalized it in the rule that stage 2 would begin no sooner than 2014, which is this year. So if you happen to be one of those EPs who started in 2011, then you actually got to stay in stage 1 for 1 additional year. Beyond that, it would still be 2 years in stage 1, and then you move to stage 2. Also originally, we had stage 3 beginning after 2 years in stage 2. And we recently announced through a blog from ONC and CMS leadership that we have made the decision to delay stage 3 implementation until 2017. So it's a similar thing that we did for stage 2. So we, instead of sort of moving everything out, we sort of said, this is the year that at the earliest you would begin stage 3, and that would be 2017. So for those of you who started in 2011, you will actually have 3 years in stage 1, and now you'll have 3 years in stage 2 before you have to move to stage 3. The other thing shown on this slide is for Medicare EPs, the amount of the incentive that you could earn in each given year, depending on when you start and what year of participation you are in. The numbers are a little bit out of date because due to sequestration, we were forced to reduce the incentive amounts beginning April of last year by 2%. So any incentive earned after April of last year would be reduced, the numbers on this slide, by 2%. But in general, you know, they're sort of in the ballpark of what you would earn. And importantly on this slide, the latest you can start for Medicare is 2014, which is this year. If you wait till next year, then there's no incentive money available to you. And the latest you can earn an incentive is 2016. All right, the basic structure of the requirements for stage 2 haven't changed. So we retained the concept of core objectives and menu set objectives. So the core objectives would have to be done by every eligible professional. And in the menu set, you would select some of them to do, the ones that were most appropriate to your practice and that you felt most ready to accomplish. So in stage 1, you had 15 core objectives and you had 10 menu objectives, of which you selected 5. In stage 2, you'll have 17 core objectives, and then there's a menu set of 6, of which each EP needs to select 3 to accomplish. So the total number of objectives is the same, 20 and 20, although as we go along you'll see that there's been some sort of consolidation and elimination of some objectives, so there will be some new stuff that you have to accomplish. All right, so another change we made to the menu set is the way that we're handling exclusions. So in stage 1, as you know, there's 10 menu objectives and you have to pick 5. But some of the menu set objectives have exclusions. So if the objective didn't apply to your scope of practice, you could claim an exclusion. And the way it worked in stage 1 is that you could actually use that exclusion to count towards the 5 that you needed to meet. So potentially you could have 3 or 4 exclusions that would count towards your 5, and you would only have to meet 1 or 2. We're changing that moving forward so that beginning in 2014, this year, if you have an exclusion for one of the menu set objectives, you need to find another menu set objective that you don't have an exclusion for. And if it turns out that out of the 6 that are available, you know, there's only 2 that you don't have exclusions for, then you'll need to actually report or attest that that's the case and that there weren't some other menu objectives that you could have used instead. So we made it a little bit higher standard on which ones you could get out of and the circumstances that would happen. A lot of things haven't changed in the way we're doing meaningful use for eligible professionals. One is that you do need to still have at least 50% of your outpatient encounters at locations that are equipped with certified EHR technology. So if you don't have at least 50%, then you can't earn an incentive under this program. We still have, for each objective, there's 1 or more measures, and in order to pass the objective, you need to meet the measure requirement. And then the denominators for these objectives and measures are based only on outpatient locations that are equipped with certified EHR technology. So if you work in 3 clinics and only 2 of them have certified EHR, then only those 2 clinics with the EHR would be used for doing the objectives and the measures. Okay, now as we move into stage 2, the EHR technology has to sort of progress to go along with the higher standards. And an important thing to understand about the way we're doing it in this program is the certification does not relate to the stage of meaningful use that you are in. Instead, it relates to the year of participation that you are in. So prior to this year, we had the 2011 version of the certification standards. And then beginning this year, we will have the 2014 version of the certification standards. So everyone participating this year, regardless of whether you're in stage 1 or stage 2, will need to upgrade their system to meet these new standards. In order to allow some additional time, because we realize that the vendors and also the providers need time to implement these system changes, we're having some flexibility in the way that you report in 2014. So rather than reporting on the full calendar year, you can select a 3-month quarter that's aligned to the federal fiscal year quarters and report only for those 3 months during 2014. So this is a 1-year only exception to the calendar year rule, and it's to allow people some additional time to implement the 2014 version of the EHR certification standards. Another change that we're making is, and there was a lot of requests for this, especially in large group practices, we're going to be allowing for batch reporting in stage 2. And so what this means is that groups will be allowed to submit their attestation information for meaningful use for all of their individual EPs in a single file that can be uploaded into the attestation system. Now, as you know, in the past, each EP had to individually go in and complete all the attestation information for themselves. And so in a large group, that became quite a burden of data entry. So to accommodate that, we're allowing batch reporting. There is a page on the CMS EHR Incentive website related to this, and I'll share that if you haven't seen that already. We will share that with the RECs, and they can distribute it to the attendees on this webinar so you can find out how to do that. All right, now I'm just going to quickly go through the new core and menu set objectives for stage 2. In general, the approach we took as we evolved the requirements are, in some cases, we raised the threshold required for an individual objective. Most of the menu set objectives for stage 1 are now core objectives in stage 2. So you sort of had 2 or 3 years experience with the objective in the menu set, and now it's time to sort of have it be a regular part of your implementation. For some of the objectives, we sort of expanded the scope or the complexity of it, so it was covering a higher level of care or a broader range of care. And then we also did some consolidation and sort of merging of some of the objectives. So you'll see for computerized physician order entry, we've raised the threshold for medication order entry, and we've added a couple of new types of orders for laboratory tests and radiology tests. For e-prescribing, we raised the threshold to 50%. For recording demographics, and for vital signs and smoking status, we raised all of those thresholds to 80%. We have a new sort of consolidated objective called interventions, which combines the previous drug-drug and drug allergy objectives with the clinical decision support objective. And instead of 1 clinical decision support rule, you now have to have 5. For the laboratory incorporation, raised the threshold to 55%. The patient list requirement now is related to a specific condition. And the preventive reminders, we've raised that threshold to more than 10%. Now we have a consolidated objective related to patient access, and we'll talk more about this in a later slide. But it's providing online access to health information for more than 50% of your patients, and also more than 5% have to actually be accessing the information. And this is part of our endeavor to improve patient engagement with your EHR system. And so there's a couple of objectives where we're beginning to include requirements where the patient actually gets more involved in their care through the use of the EHR system. For the visit summaries, we raised that threshold to 50%. For educational resources identified through your system, we've changed that threshold. A new one, and introduced it into the core without going through the menu set, is a requirement for secure messaging. And this requirement is that more than 5% of your patients send secure messages to the EHR or to the EP through their EHR related to their health care. This is another component of the patient engagement that I mentioned. And you'll notice that both of these were starting at a pretty low threshold of only 5%, since this is the first time you'll be doing that. For medication reconciliation, we raised that bar to 50%. The summary care document, again, we've sort of expanded it so that not only do you provide it for more than 50% of the transition of care and referrals that you do, but 10% of those need to be transmitted electronically, and at least one needs to be transmitted to an EHR system that's a different vendor, so sort of completely outside of your system. Or alternatively, we will be setting up a CMS test EHR that you can do that transmission to. And the idea behind this is that, you know, it's fine to send the summary along with the patient, but we really want to facilitate interoperable exchange of health information, not only within systems but across and between providers. And so we need to begin to make that a requirement for meaningful use. For immunizations, as you know, in stage 1, you just had to do a test of transmission to a state or local immunization registry. Now there's a requirement for ongoing transmission. And then there still is a requirement for security analysis to make sure that you are protecting the information in your EHR systems. Okay, for the 6 menu set objectives, again, these are, with one exception, they're brand new objectives for stage 2. The exception is syndromic surveillance, which we had in stage 1. But since there's really kind of sporadic availability of these systems around the country, we didn't think it was quite ready to go to a core objective. So we're leaving it in the menu set. But the new ones relate to storing of imaging results. So at least 10% of imaging results are accessible through your certified EHR. You need to record family history, more than 20% of patients. We have 2 new types of registries, cancer registries and other specialized registries, where you would be required to have ongoing submission of the appropriate data. And then the last menu set objective is the documentation of electronic progress notes for more than 30% of your patients. So out of these 6 menu set objectives, each EP will need to select 3 that they can accomplish in order to meet meaningful use. Okay, so I talked about patient engagement. And if you look at sort of the high-level goals of what we're trying to accomplish with EHR implementation, a big part of that is trying to have a greater involvement of their patient and their family and their caregivers in their health care, and improve that interaction with their health care provider to empower them to sort of be more involved in the decisions and more informed about their care. So we have a couple of parts of objectives that are related to that I've mentioned. So one is the secure messaging requirement that more than 5% must send a secure message to their EP. And then there's a part of the health information access online. Again, more than 5% must actually access the health information online. Now, when these first came out, we got a lot of pushback from the provider community saying, you know, I can't get my patients to do this, and my patients don't have computers and they're not really tech savvy. And we heard that, and that's part of the reason why the thresholds are so low. But there's also information that's come out even before that, despite the claims that the elderly population are not online and they don't have computers or use computers, the studies that have been done actually show that it's a fairly large percentage of patients over 65 who have access and regularly use the internet and email and things like that. So I don't think it's going to be as much of a challenge as people believe. The other thing to keep in mind related to this is that it's not just the patient, but it could also be the patient's family member that's helping them with their health care. And most likely, if it's a son or daughter, they're going to be more tech savvy. So we know it's new and it's going to be challenging, but we don't think this is an unreasonable expectation. Another thing we did for electronic exchange is we're looking at a more actual case or actual use cases for electronic exchange. So in stage one, it was just did you have the capability, and now we want to actually see the exchange happening. So as I mentioned earlier, while 50% of your transitions of care need to have a patient summary, 10% of those need to be done electronically, and at least one needs to be done to a different EHR vendor. All right, so that's sort of stage two. I do want to review some of the stuff in the rule related to changes in stage one. Although most of those, since we're already in 2014, are kind of past, there's a couple that are ongoing requirements for stage one. So one thing we did for computerized order entry is we provided some flexibility in the way the denominator for that could be defined. So as you know, in the original stage one measure, we looked at unique patients who had at least one medication in their medication list, and then we said a certain percentage of those had to have CPOE. But there were situations where patients would have medications on their list that were put there by a different EP, and then the EP who was trying to achieve meaningful use actually didn't prescribe them any new medications, and so it was challenging for them to meet this objective. So to improve the flexibility there, we've provided an alternate denominator, which is the number of medication orders during the EHR reporting period. And so that way, if you don't have any orders, then you don't, or if you have very few orders, then the requirement would be smaller. And so this is optional. It was optional through last year, and or actually it's optional for stage one beginning last year. So going forward, you will always have this opportunity to use this alternate denominator. We made some changes to the vital signs objective. First, we changed the age ranges to be more compliant with the current guideline recommendations. And then the other thing we changed was the way that you can use exclusions for this objective. Originally, it was sort of all or none. So you had height, weight, and blood pressure. And unless all three of those were not applicable to your practice, then you had to meet the measure. But we heard feedback that, for a lot of providers, blood pressure was relevant, but height and weight weren't, or vice versa. And so we split those apart, so then now you can sort of claim a partial exclusion for one or the other if both are not relevant. So, for example, if you felt that blood pressure was relevant to your practice, but height and weight were not, then you would not be required to collect the height and weight on the same percentage of patients. In terms of testing of electronic exchange, this was a confusing objective for a lot of people in stage one, and it actually didn't get us a lot of utility in stage one, and so we've made the decision to just remove that requirement completely in terms of the one test of electronic transmission. The thinking behind that is that when you get to stage two, because we have our actual use cases of electronic transmission, you would have had to do some testing along the way in order to get there, so that would essentially meet the intent of this objective. And then for the objective related to e-copy and online access, as you know, in stage 1, they were 2 separate objectives. One was electronic copy of health information upon request, and the other was provide electronic access to health information. We've consolidated those two to providing access, the ability to access, download, and transmit health information. And this will be the new objective with the 2014 version of certification. So since everybody has to upgrade to the new version of Certified EHR technology, all of your systems will have this capability, and so we will be assessing just this consolidated objective going forward. A small change to the immunization and lab and syndromic surveillance reporting for stage 1. We added some language. It actually doesn't change the objective. It just clarifies the intent that has been there all along. So we added the phrase, except where prohibited, to all 3 of these objectives to make it clear that it's sort of not an optional data submission activity. It's something, as long as you are able to do it and there's a system in place to do it, then you would need to do that. All right, I'm going to spend the next few minutes talking about the changes to the clinical quality measures related to stage 2, or actually I should say related to 2014. So prior to this year, the CQMs remain the same. So for those of you who have just finished completing meaningful use for 2013 and you're in the process of attesting to that in the next month or two, you will be using the old CQMs that were in stage 1. And that was a system where we had 3 core measures or 3 alternate core measures if one or more of the core did not apply to you, and then 3 additional clinical quality measures that you would select to report. And back in 2012 and 2013, there were 2 options available to report. You could either do it through attestation as part of the overall attestation for meaningful use, or you could have elected to participate in our pilot electronic reporting through the PQRS system. In the Medicaid side of the house, you would still be reporting to your state, so there would be state-based submission requirements. So that was for 2013. And there was no need to update the specifications, or we were not going to. We basically left everything the same prior to this year. Now, there was a situation, or there may have been a situation where, as you were moving towards the new certification standards last year, you may have actually acquired the new version of the EHR technology before the end of last year. And so there would be a period of time where you had sort of part of the year using the old system and part of the year using the new system, and so you would have to merge those 2 clinical quality measures together. So the implication of this is that there were some of the measures that were not carried forward to the new 2014 EHR technology. And so if that was one of the measures that you had tried to report, you wouldn't be able to report that for the last part of the year where you had the new technology. The main consequence of that is that one of the core measures was affected by that circumstance, and so you would be forced to select an alternate core measure to replace that. But still, the overall system would be the same, would be 3 core, alternate core, and then 3 additional to report. Okay, so as I think I mentioned earlier, the CQMs now and going forward are not related to the stage of meaningful use that you're in, but they're related to the version of the EHR technology that you are using. And so we had 2011 version of CQMs, now we'll have 2014 version of CQMs, and then in a few years we'll have the 2017 version of CQMs. And so the requirements, it won't matter whether you're in stage 1 or stage 2 or stage 3, it'll just depend on which year you are reporting. All right, so for stage 2, or actually for 2014, the requirement has changed now. So instead of the 3 core, 3 alternate core, 3 additional, we now have a set of 64 measures of which you will need to select 9 that cover at least 3 of the National Quality Strategy domains. And those domains are shown on this slide. So we have patient and family engagement, patient safety, care coordination, population and public health, efficient use of health resources, and clinical processes and effectiveness. So each of the clinical quality measures has been mapped to one of these National Quality Strategy domains. And as you're selecting the 9 that you want to report, you need to make sure that you've covered at least 3 of these domains. The other thing we're trying to do with the clinical quality measures is to align them across our other CMS programs. We want to do this to potentially reduce the reporting burden, but also to sort of synchronize our efforts towards the National Quality Strategy goals so that not only is the EHR incentive program promoting those goals, but also our other quality programs are promoting them in the same way. And so we're aligning on the physician side with the physician quality reporting system and also with the Medicare Shared Savings Program or the ACO program. So you'll see this year and going forward, there's the opportunity to report the same measures and get sort of double credit for those 2 programs, depending on which ones you're participating in. And as I mentioned, we hope that this will also allow you to reduce or eliminate multiple submissions of the same data to different places. So for eligible professionals, you'll have the option of submitting the data electronically for PQRS and having that data count towards your meaningful use requirements under stage 1 or 2. And also if you're in the Medicare Shared Savings Program or Pioneer ACO, they also have a mechanism of submitting quality measures electronically, and if you meet those requirements, that would also count towards your meaningful use requirement. So we posted the list of CQMs on our website and also the mapping to the National Quality Strategy domains. We've also listed a core set of CQMs that we are recommending, although they're not required or mandated. But the idea behind these core CQMs is that they align with a number of other efforts going on in the department in terms of our national initiatives. And they are also have a number of other important characteristics that we think will provide a greater benefit to the patient population. And some of these benefits are shown on the next few slides. So we look for conditions that contributed the most to the morbidity and mortality of Medicare and Medicaid beneficiaries, ones related to national public and population health priorities, ones that were common to health disparities, things that disproportionately drove healthcare costs and could improve with better quality measurement, and things that would enable the CMS, states, and the providers to measure quality with a stronger focus on a parsimonious measurement approach. So if we're all sort of measuring the same thing and working on the same things, that could improve coordination and improve the overall impact on these measures. And then finally, things that would include patient and or caregiver engagement. And we've talked about that a little bit on this webinar about the importance of including the patient and their family in the healthcare decisions. All right, so just at the high level for CQMs, the CQM requirements do not relate to the stage of meaningful use, but instead relate to the year of meaningful use that you are reporting. And as similar to in the past, the way that you report the CQMs to us is a direct output from your certified EHR technology. So it's what your system produces, unaltered. So we don't want you to use other sources outside your certified EHR, and you shouldn't manipulate the output once it comes out of your EHR. All right, so this just shows some of what we'd already talked about, the change in requirements. So in 2014, you'll report 9 out of 64 CQMs. They must cover 3 of the 6 national quality strategies, and there's a recommended core set that you may elect to report. All right, now depending on which year of participation you're in, are you just starting out or are you further along, the period that you need to report and the timing of that reporting is different. So if you're in your first year of meaningful use, you will be reporting aggregate data for all payers. You will be attesting to this, similar to what you've done before. But again, you'll be 9 out of the 64 CQMs covering 3 domains. So the main reason for the attestation being the only way to do this is, as we'll talk about later, the Medicare payment adjustments require that we have the information early enough in the year to make the decision about whether to apply the payment adjustment to the EP's Medicare reimbursement. And the only way to accomplish that early notification is through the attestation system. But if you're beyond that first year, then one option is that you could submit electronically. So you could use your system to submit aggregate data on all payers electronically using the specified QRDA standard. Or you could continue to attest the information. Originally, we had the requirement that it needed to be electronic for anyone past the first year, but there were some difficulties with the version of the CQMs being out of sync with what CMS was capable of receiving at the time that it would be ready, and the vendor's ability to sort of keep that updated in a timely fashion. And so since we were unable at this point to kind of reconcile those inconsistencies in timing, we provided some additional flexibility in our recent physician fee schedule final rule that you could continue to attest the CQMs as one option for meaningful use. The other option you could do is if you are participating in the PQRS program and are using the EHR method of submission for that program, then that would also count for meaningful use. The key difference there is that it's patient-level data, it's for a full calendar year, and it would be primarily Medicare patients that you would be submitting electronically. If you're in a group practice, either in one of the ACO type groups, Medicare Shared Savings or Pioneer, or if you're in one of the PQRS group practice options, then if you meet the electronic reporting for those 2 programs, then that would also count towards your meaningful use requirements. All right, so in terms of the timing of reporting, there's really no change from stage 1 to stage 2. Again, it depends on the year that you're reporting. So in your first year, you will do 90 consecutive days within the calendar year, and you can report any time after that 90 days is up. Following that, you will do a full calendar year, and then you'll report within 2 months following the end of that calendar year. Now, there's a special exception for this year because of the transition between the 2011 and 2014 version of Certified EHR technology. And so since you're only reporting on a calendar quarter for your other meaningful use objectives, similar requirement applies to the clinical quality measures. So you would select the calendar quarter to report, and then any time following that calendar quarter and up to the 2nd month at the end of the calendar year, you could submit those clinical quality measures. All right, we'll wrap up here talking about the payment adjustments and hardship exceptions for the Medicare side of the EHR incentive program. The payment adjustments are in the statute. They're a requirement that payment adjustments be applied to Medicare providers who are not meaningful users by 2015. And you become a meaningful user when you successfully attest to meaningful use under either the Medicare or Medicaid EHR incentive programs. So it doesn't matter which side you are using to achieve meaningful use, since the requirements are pretty much aligned between the two programs. But importantly, it does need to be meaningful use and not adopt, implement, and upgrade. So as you know, on the Medicaid side, you can earn an incentive for adopt, implement, and upgrade, but that does not equate to meaningful use in terms of helping you to avoid the payment adjustment. Now, the payment adjustments begin in 2015, but the requirements that you need to meet to avoid the payment adjustment actually precede that by between 1 and 2 years. The reason for this is that in order to get the information about whether you've met meaningful use in time to implement the system changes effective January 1st of 2015, we needed between a 1 and 2 year lead time to make that decision. This slide just shows the amount of the payment adjustment that would be applied if you do not meet meaningful use. And so you see that it starts in 2015 as either 1 or 2% reduction in your Medicare payments, depending on your participation in the prescribing incentive program. And then it gradually increases from 99 to 98, or decreases from 99 to 98 to 97 as each year goes along. Now, you'll see that there are slight differences between the table at the top and the table at the bottom. The table at the top is assuming that less than 75% of EPs nationally achieve meaningful use by calendar year 2018. The statute gives the Secretary the discretion to increase the payment adjustment to drive further adoption of EHR technology. The table at the bottom is assuming that more than 75% of EPs have reached that level. And by the data that has come out for the end of 2013, I think we're estimating that we already have 60% of EPs who have met meaningful use, and about 80% of them have registered to participate in the program. So I think it's likely that by calendar year 2018, we will have surpassed that 75% mark, and so we will max out the payment adjustment at 3%. That's just my guess at this point. All right, so if you began your meaningful use in 2011 or 2012, you would need to have met meaningful use for the full calendar year 2 years prior to the year of the payment adjustment. So for the first year of the payment adjustment in 2015, you would have needed to meet meaningful use for 2013 in order to avoid that payment adjustment. And then like going forward, it's a 2-year lag. An important thing to understand is that this is not a one-time, once you've met it, you're off the hook for the rest of your life. This is something that you need to meet every single year in order to avoid the payment adjustment 2 years down the line. And then finally, if, not finally, but if 2013 was the first time that you were meeting meaningful use, you would have a 90-day reporting period to meet that, and that would help you to avoid the payment adjustment in 2015. But after that, it would be a full calendar year. And then finally, if you hadn't met meaningful use until this year, then you have a 90-day reporting period for this year to meet meaningful use. That would actually get you off the hook for both 2015 and 2016. But then after that, you would need the full calendar year of reporting to avoid the subsequent payment adjustment in 2017. All right, so if you are eligible for both programs, so you know that eligible professionals could be either on the Medicare or the Medicaid EHR incentive program. Even if you're doing the Medicaid EHR incentive program, if you also have Medicare patients and you want to avoid the payment adjustment for those Medicare patients, you do need to meet meaningful use. And as I mentioned earlier, not the adopt, implement, and upgrade. That would not be sufficient. We did outline some hardship exemptions or exceptions for those who had reasons for not meaningful use that we thought were reasonable. So one is that if there were infrastructure issues related to high-speed internet in the area where you practice, lack of broadband access, that could be an exclusion. If you're a new eligible professional, then we give you a time-limited 2-year exception. If you were unforeseen circumstances, such as natural disasters, we would take that into consideration. For certain EPs that lack face-to-face interaction with patients and also lack follow-up with their patients, they could claim an exception for that. And then finally, for EPs who practice in multiple locations who can demonstrate that they lack the control over the availability of certified EHR technology for more than 50% of the patient encounters, we would consider that. Since, as you know, you need to have at least 50% certified EHR technology in order to qualify for the incentive. If you didn't have that control, we would consider that as an exception. For one of these, about the patient encounters and follow-up, we've identified 3 subspecialties that if your PACOS record indicates those as your specialty, you will sort of automatically get an exception based on that specialty. And the 3 are anesthesiology, radiology, or pathology. So if you are in one of those 3 specialties, and if your PACOS record reflects that, then you do not need to apply for an exception. Otherwise, all of the other situations I described, you would need to submit an application for the exception and have that approved by CMS. So you would apply. They would be granted only if we determined that it was a barrier to you achieving meaningful use. And the deadline for those applications for eligible professionals will be July 1st. You can do it earlier, and we encourage you to do it earlier. So if you happen to fall in one of those categories and you think you will meet the exception, then go ahead and submit that application. You can get information and details about how to do that through our EHR Information Center. All right, so one last thing about Medicaid. There was one change that we made to the Adopt, Implement, and Upgrade criteria, and that is that we aligned it with the version of certified EHR technology. So starting in 2014, in order to earn the incentive on the Medicaid side for Adopt, Implement, and Upgrade, you would have needed to have adopted the current version, current certification version, which is the 2014 version. So it wouldn't be good enough to adopt an older version of certified EHR technology. We have lots of information on our website and resources about how to participate, the specifics about all of the objectives, the timelines, and useful tools to help you to figure out sort of where you are, how much your incentives might be, and other resources to help you. Lots of tip sheets with examples to help you work your way through the details of meaningful use. We also have the EHR Information Center, which I've mentioned several times. They will be your resource for anything having to do with registration or attestation or payment of the incentives, also applying for hardships, and also they may help you with things like batch reporting and things like that. So their phone numbers and hours of operation are shown on this slide. And then finally, if you have questions, you can submit them to us in the regional office at the email address at the top of this slide. You can also attend our national provider outreach calls, which happen periodically, and they usually have an extended Q&A session on those calls. And you can also go to our eHealth website. And of course, as all of you know on this call, you can work with your local REC, who will provide you technical assistance and answers to all of your questions, sort of boots on the ground. So they are also a tremendous resource for you moving forward. So with that, I will leave up this contact information as the last slide. And Veronica, I'm not sure how I turn it back over to you.
Thank you, Dr. Nilasina. There's some questions here. The first one, is there a group size restriction to apply for the batch reporting?
So that's a good question. Is there a size restriction to apply for the batch reporting? I don't believe there is. I mean, that's sort of the whole idea, is that the larger the group, the greater the need for batch reporting. And also I don't believe there's a minimum size. But as I mentioned, I will be sending out the link to that page on our CMS website, and they have all the details there about the exact requirements for batch reporting, and I'm sure if there are any restrictions, they would be on that site.
There's another question. How does the payment adjustments affect the FQHCs?
Well, that's a good question. It doesn't affect the FQHC as an entity. However, it may affect the individual eligible professionals within the FQHC. As you know, each individual eligible professional may have Medicare patients that they bill through Part B, either as a separate practice outside the FQHC, or I guess there may be some FQHCs that allow that. I don't think so. But if you are an EP that bills Medicare, and so you potentially could have earned the EHR incentive payment, then you would also be subject to the EHR payment adjustment if you do not continue to meet meaningful use. So it's sort of on an individual by individual basis, depending on their Medicare patient profile and the way that they bill Medicare.
Okay, well, thank you very much. That's all the questions I see here. Well, I see another one, but I think we're running out of time. I'll make sure you receive an answer. I want to thank our speaker for taking time out of his busy day to share his knowledge with us. If you have any questions for today's presenter, please email Texas Rec using the email shown, and we will make sure you get an answer. Please join us next month for our next educational webinars in the series. We'll be presenting ICD-10, what you should be doing to prepare. It's going to be on February the 5th, and hope to see you there. Thank you for attending today's webinar. Goodbye.
Thank you, everyone.